welcome back to another episode of Conversations with Jen. Now, as you can tell from the set, I am still not in the UK. I'm in Jamaica, and I am sitting down with a very special guest. This is my first conversation that I'll be having with a medical professional. So please, special guest of mine, introduce yourself and tell the people who you are and what you do.
Hello, everybody. I'm Professor Jenica Knight-Madden. I am actually a pediatric pulmonologist. I'm not a hematologist, but I have been working at the sickle cell unit since 1997. And before that, my research was sickle related. So I've been interested in sickle cell disease for a very long time. So in terms of training, I did medicine in Jamaica and Barbados, my pediatrics in Toronto at Sick Kids, my pulmonary at Duke in the US, and my PhD at King's College in London.
Wow, so you're kind of worldwide.
Right. And then I've done a couple of short courses since then, but my family says I'm no longer permitted to do any more studying. It's been enough. So that's that. But it's great to be talking with you today, Jen. And
Thank you.
I think it will be fun.
Thank you. Thank you for joining me. So my main reason for really wanting to talk to you is because I'm really interested in the differences in terms of, sickle cell in the Caribbean. Of course, I grew up living with sickle cell, but in the UK. And I myself have noticed that when I'm in Jamaica, when I'm in this climate, I'm a lot healthier. I have, less crises, less chronic pain, less fatigue. But being registered at the unit, because I spend a lot of my time here, I still see people living with sickle cell, still riddled in pain, still, having some of the same issues that I've kind of escaped. So what makes me so well, but what keeps some people that live in Jamaica or live in the Caribbean still having some of these common complications of sickle cell?
I want to tell you that the thing that distinguishes sickle cell disease from so many other diseases is the unpredictability. Mm-hmm. So clearly for you, your triggers are less here. So you have less pain and so on. Mm-hmm. But other persons who live here, their triggers are here, right? So back in the day, we used to talk about sickle cell disease as all about obstruction of the blood vessels, right? You have these cells that they sickle, they stick together, they block the blood vessel, and that's it. Mm-hmm. There's so much more to it. All right, so sickle cell disease is called sickle cell disease because the red cell, instead of being round, assumes a sickle shape. Right. So we either call it banana cell disease. Yeah. But we'll go with the sickle cell disease. So what happens is that inside that cell is hemoglobin. Hemoglobin is what makes the blood red, and it carries the oxygen around the body. When you have the sickle hemoglobin, inside that hemoglobin is iron. In normal adult hemoglobin, the iron is hidden away. Okay. In sickle hemoglobin, it's exposed, and iron reacts with everything. He's a busy guy, right? And so you get all these different chemicals made that cause mischief. Mm-hmm. Good. Mischief in the red cell. And the red cell then sticks to each other and to the actual lining of the blood vessel and damages the blood vessel. So you actually get an inflammation of the blood vessels. Mm-hmm. And then what happens is that happens wherever the blood goes. So it doesn't go to your hair because your hair is dead. Right. But everywhere else in your body, the blood goes. So sickle cell disease can cause an acute problem or a chronic problem anywhere in your body. But some people have it and some people don't. So you have children who will be dead by the time they're 4 months if you don't diagnose them at birth. And then you have people that toddle in at 60 and say, you know what, they took out my gallbladder and the stones were black and they tell me I have sickle cell disease, and they didn't know.
And they didn't know.
And everything in between. And you'll have people who are well as children and sick as adults, or sick as children and well as adults.
And there's no way to there's been no way or no research to be able to tell, like, is it a variation in the hemoglobin?
There's
like,
some
what
things.
Is it?
So like if you inherit more hemoglobin F, which is fetal hemoglobin, that kind of gets between the S and makes it less troublesome, you do better.
Okay.
If you have an alpha thalassemia trait, which kind of balances off with the beta, again, you tend to be, but in a lot of cases, we don't know why, right? But that said, it's not that we throw up our hands, right? Because even though we have less money and resources than in somewhere like the UK, a lot can be done with very little.
Yeah.
So the first thing is that Jamaica has universal newborn screening, and that is amazing for such a resource-constrained country. And, you know, kudos to our politicians and technocrats in the Ministry of Health who have allowed this to happen.
Yeah.
And it all started because the patient group, the foundation, pushed for it.
This is the Sickle Cell Foundation.
The Sickle Cell
of Jamaica.
Support Foundation of Jamaica has made a tremendous impact. So I want to tell you, if in your little area is only 2 you have sickle cell disease, you can still get together and lobby. And it can still make a difference because we have seen it. Small group with a big voice, right?
That's interesting.
So the first thing is that you need to actually diagnose the sickle cell. So in Africa, if you're born with sickle cell disease, chances of making it to 5, maybe 30, 40%. Jamaica, you're born with sickle cell disease, chances of making it to 5, same as if you didn't have sickle cell disease. Because you get penicillin, vaccines, and your parents are taught to feed your tummy every day. Now, that has got to be the cheapest intervention ever known to man.
Yes.
Yeah? And it used to be that the commonest cause of death in children with sickle cell disease under 2 was a problem with the spleen.
Yeah.
We don't see it now. We see it, but
Well,
it doesn't kill them
yes,
because the parents feel it,
know
bring
what to
them in
do.
early, and they don't die.
Can I ask, what about folic acid? Is that not...
Okay, folic acid is used... okay, why folic acid? Folic acid is a building block of hemoglobin. Because of the sticky nature and the fact that the cells get rigid, the red cells break down much quicker, sometimes an average of 2 weeks, right? In people who don't have sickle cell disease, the red cell lasts 4 months.
Longer.
It's a huge difference, right?
Yeah.
So what happens is the poor body's there working to make more cells. Now, when you break down the cell, that's actually why you get jaundice, right?
Yeah, the
Is
cells
because,
break down
right,
quicker than the body.
part that makes bile, and bile is excreted. But the body takes back the stuff it can use again, the iron, the proteins, and so on. But one of the building blocks that it needs to go into the new cells is folic acid.
Right.
And folic acid comes from green leafy vegetables. So if you're not eating green leafy vegetables, then especially if your spleen is big, so you're chomping up those red cells, or you're in a growth spurt or so on, then you need that additional folic acid. If you actually have a good diet, and your spleen is not big, you probably are fine without it. So sometimes it's not going to hurt you if you get it. So people will say, all right, just in case you need it, go ahead and...
Because in the UK was penicillin, folic acid. Those were the 2 things that I was on until I kind of done research into what folic acid was. And I mean, now that I'm here, I like anything that's natural that I know I can get folate from, my folic acid from, I'm having. And
that's
I feel
ideal.
like,
That's ideal. And then you don't need a pill because you're getting it all naturally. So, you know, we're able to do the screening, we're able to do those, we're working on the hydroxyurea. We don't have a lot of blood, right? And so we don't transfuse as much as in other places. But we have found that it's often not as necessary as you might think, right?
Yeah.
So you don't have to transfuse everybody before they have surgery necessarily, depending on what their hemoglobins are and so on. And
so are you saying then that, because in the UK, you know, I dare say we have access to blood. We have a blood bank, and now blood transfusions are a regular form of treatment across the board. It's like if people are not on hydroxy, they will be on transfusions or exchanges, like without a doubt.
Yes.
Are you saying then that, you know, for you guys not having that access, you still have healthy patients, patients that are living longer, that are able to kind of go through, like, is it necessary? Like, what's being done, or?
You know, as you heard, I've traveled,
Yes.
and one thing I'll tell you is that what is gospel in one place, they look at you really strange when you say it somewhere else. Because a lot of medicine is art as well as science. And so as long as there's evidence to back up what you're doing, it's okay. Now, we just don't have an option. We don't have the blood. But, I mean, blood is a very serious intervention, so you always have to consider carefully whether you really need it. And so the doctor and the patient have to work together to consider whether or not they really need it. The blood supply in Britain is pretty safe. I mean, I think you're over the mad cow issue. And so no, I mean, things like HIV, Hep C, those things are sorted. And so it's safe. It's safe here too, we just don't have enough of it. So in general, there have over the years been two camps in sickle cell disease, the chronic transfusion camp and the hydroxyurea camp. I mean, this isn't just in the UK, it's, you know, in the US and so on. And I think that we have tended towards hydroxyurea because we don't have blood. But I would say that at this point in the history of sickle cell disease, I think more people are towards hydroxyurea than chronic transfusion.
So would you say then, if you did have the kind of resources of having a blood bank or having access to blood, would that be a form of treatment, you know, that you would use for your patients here? Or do you think that what you do works sufficiently enough?
Okay, so we have a blood bank that works really well. What we don't have is enough people donating. If we had more blood, there are some persons that we might have used chronic transfusion in more. Maybe some of the people with renal failure, we would transfuse more often and so on. We don't have access to inexpensive chelation. So when you give people blood, you actually are giving them iron. And the iron does accumulate in the body, in the liver, in the heart, and so on. And then you actually have to use drugs to get the iron out. And so we don't have access to that easily, and it's extremely expensive. And so we still would not use chronic transfusion in the same way that is probably used in other places, just because we would know that down the line, we'd be running into problems.
More problems, yeah. That was one of the things. So I was on transfusions every 4 weeks for, I think, almost 3 years, but the iron build-up and iron overload was then problems with my liver. And it's like I realized very early on that even though we do have access to treatments, and there are some very good treatments, some better than others, for me, a lot of the, okay, so I had a stroke, I was put on transfusions, but then the side effect from the transfusions was the iron overload. So then I had to take something because it was causing problems with my liver, and to treat that caused another problem. And then you just end up being on this kind of zigzag of, you know, you're trying to fix something.
For stroke, the data are pretty strong that the best treatment for stroke is chronic transfusion.
But for the rest of the person's life?
So we use hydroxyurea because we don't have the blood. And hydroxyurea is definitely better than nothing, but it's not quite as good as blood. So again, I mean, you have this switch trial, all kind of trials where people who can't go on to continue on blood are put on hydroxyurea and they see benefit. Medicine is individual.
I know.
And you have to, decisions have to be shared. You know, I teach my medical students that I'm not about compliance. Compliance is I, the doctor, tell you what to do, and you go home and do it because I am the expert. No. I'm about adherence. Adherence is let's make a plan that you think can work for you, that is the best that I can advise you on, give the options. Where you know the options, we discuss them, And then you are invested, you understand why you're doing what you do, and you go away and do it. Two very different things.
I mean, it sounds beautiful. It sounds like music to my ears. That whole, listening and conversing and coming up with something that works for the patient, as opposed to this is what we do, this is what everyone does, and so you have to follow the same guidelines. How do you deal with, or if you have ever dealt with, patients where they're just not compliant with anything? They don't want to be on any form of treatment. They don't want...
When I was in Toronto, we used to, go to the court and take away children sometimes. They're going to die if they're not transfused. You get a judge, you take away the child. Granted, they may never go back to their family because they might not accept a transfused child back into their house.
Okay.
Right?
For religious reasons or whatever reasons?
Usually.
Okay.
So it's not a light decision, right? It has to be that this child is going to die in your hands. But adults can choose. If you want, having been, if you're competent to make a decision, it's not that you have dementia or something, but you just choose not to be treated. It's your choice. I can't do anything about that. It's difficult. I've known people who have died of some very preventable things.
Just because they just don't want,
But if you're an adult, you have agency, right? What you have, one of the things that again is important is how you explain things. Jargon, no. Big words, no. I think that sometimes if you actually explain to people why it is you think they should do what you think they should do in a way that they understand, they might change. But then sometimes they can explain to you why it is that despite what you're saying,
they don't want it.
No. And you have to accept that.
That's true. If there's one thing that you could, well, you probably already are, focus on or change or make a big impact in the field of sickle cell, what would that be, or what is that?
Well, right now, I'm co-chair of the Sickle Cell Technical Working Group in Jamaica. And I didn't know I would have seen this kind of progress in my lifetime, and it is all about collaboration. So it's led by the Ministry of Health. The sickle cell unit is there with our lab, the other lab that does newborn screening, people from each of the regions, doctors, nurses, lab techs, patients, critical patients. And the progress that we have seen has been steady and way beyond anything I thought I would have seen. Just recently, we had the first National Sickle Cell Disease Review, and there were over 1,000 people logging on.
Wow.
I have not been on any other occasion, virtual occasion in Jamaica with 1,000 people.
Wow.
And these were from right across the island, different kinds of professionals as well as patients. And what we're trying to do is, instead of being this ivory tower of a sickle cell unit, we're a source of light, and we're basically lighting other lights around the island through training and just enabling, so that people don't have to travel far. And then we're piloting tools. So we're piloting a passport, which the patient will take wherever they go. So when you come to me, I can leaf through and say, oh, you're in A&E for pain and they gave you this. Oh, you went to that place for your leg ulcer treatment. Right. And then I have a much better continuity of care, and I can give you better care. We're doing an encounter form. So if you're a doctor who doesn't see a lot of sickle cell disease, it tells you, ask about leg ulcer, ask if they're on hydroxyurea, ask if they have a National Health Fund card. It cues you about the things to ask for. And it cues you, are they jaundiced? Do they look pale? Is the spleen big? It's all there on the paper. So they fill it out, and over time they'll become more and more expert in treating sickle cell disease. We're doing registers. So in other words, what we're working on is trying to bring the care that we've developed in the unit right across the island and across the region. So we've been doing trainings. We did Dominica recently. We're supposed to do Belize and St. Lucia soon. We've started a sickle cell disease scorecard. So far, only 3 countries,
But it's progress.
Haiti, Jamaica, and Guadeloupe. But once we have it across the region, then you can look and you can say, oh, if I want to do newborn screening, the countries that do that well are, let me call up that person and ask them if they can come help me in my country to get newborn screening going and that kind of thing. So collaboration across the region.
Amazing.
So I'm vice president of CARIS, which is the Caribbean Network for Researchers in Sickle Cell Disease and Thalassemia. Very unusual. French, Spanish, and English-speaking countries working together as one in the Caribbean about sickle cell disease. Yeah, it's crazy.
She's like, yeah, I did that.
No, not me. I mean,
no, but
I'm saying that
you're a part of something that is needed, and
Yes.
it's making a huge impact.
Yes.
And it's about, I always say there's something that I feel like is not done great in the UK, which is sharing best practice. So this is what's working here. How can you help us to implement that in this city? Because, you know, in the UK, everything's, you know, London, they have things that work, you know, greatly. But then in the outer regions, even, okay, so I'm from Birmingham, the second city, the second largest population of people living with sickle cell, and it still seems like they can't get it right, but they have these conferences and we have all these things. So it's great what's taking place is that it can be done. And so it gives me hope anyway for kind of other countries to hopefully be able to learn from what you are a part of. And
well, I think I just came from the Global Congress recently in Paris, where I reported on the Caribbean status. But it was very interesting listening to people from, Brazil and India, because, India has a lot of sickle cell disease, and Europe and Americas and so on. And I think that sickle cell disease is coming into a purple patch. And I don't mean that in the KC way. For the Jamaicans who know what I'm talking about, right? That's a school that wears purple, and they just think they own purple. No, I'm not talking about KC. A purple patch is a patch where things just seem to work.
Yeah.
And I think it's because there's a set of people in positions in different places that really are collaborative. And so I am hopeful. I'm more hopeful than I used to be.
Yeah.
And I encourage people living with sickle cell disease, because we try not to say sicklers these days, right? Because we don't define people by their disease.
By their disease.
To be hopeful. Sickle cell is a rough disease. As I said, it can affect everywhere in your body, and it's unpredictable. But despite that, try to be the best that you can be. Try to make use of what resources are available. And on those really rough days that will come, make sure you have your support system in place that can carry you when you can't carry yourself, because all of us need that.
Amazing. Thank you. Before I go, do you have any questions for me? You may not.
Well, I mean, what's next for you? I mean, you're in Jamaica for a while, though.
Yeah. I know we keep crossing paths so much. I'd like to kind of see how I can be a part of what's happening in Jamaica, be a part of the growth. I feel like I have tried to do as much as I can in the UK, and the work is still, it's ongoing. Even though I'm not there, I have a team of people that are continuing to raise awareness, to educate people. But it's interesting just to see the difference and to see where I can make an impact. I don't want to, like you said, it's all about kind of working collaborative. So, I've collaborated with the Sickle Cell Foundation. We've done donation projects. I've been able to share my books. I'm collaborating with Warriors Unite. So just seeing how I can assist or learn even from what's already taking place, I think is the next thing. And I'm kind of passionate to go all over. Like, I've been to Nigeria, I've been to Gambia, now I'm in Jamaica. I want to kind of just see.
Right. Yeah, I've only been to 2 countries in Africa, South Africa several times, because I worked on the sickle cell disease ontology, which was a global initiative that was is headquartered there.
Okay.
And I've been to Congo Brazzaville, but I think I'll probably try to go to Ghana next.
That's on my list as well,
Yeah.
Ghana. It's been great speaking with you. Thank you so much for joining me.
You're very welcome.